All right, folks, welcome to the MMOA podcast brought to you by the Institute of Clinical Excellence. My name is Dustin Jones, and today we are with Dr. Jake Sosnoff. He is a faculty member, Assistant Dean of Research at Kansas University. Is it University of Kansas?
It's the University of Kansas, but we go by KU just to
Very confusing coming from the guy in Kentucky.
Yeah, well, that's why. Because of Kentucky, we go by KU instead of UK.
All right, so KU, we got a Jayhawk on here. We're going to be talking about falls preparedness, falls landing, and some interesting research out of Jake's lab that is looking at how we can help potentially reduce injurious falls once they're happening, and some very innovative and progressive research on training people how to fall in a manner that could hopefully reduce the risk of an injury. So I want to start off, and I want all of y'all that are watching or listening to check out Jake's faculty profile and all the research that he's done. But I'm curious, from your angle, why or how, what's the background on you getting to this point, which I'm sure it's long, but getting to the point of literally training people how to fall and measuring the result of that? Because I can only imagine, I've never done any research or any RCTs involving different interventions, but as a clinician practicing this stuff and using it with folks, it's very intimidating. It's very scary and could be perceived as very risky, right? And so I'm curious of how you've gotten to this point, because it's very new and novel and you don't hear a lot about this.
Yep. No, you're right on, Dustin. This idea came about, and I want to make sure I give credit. So I had this wonderful PhD student, Yejin Moon. She's now an assistant professor at Syracuse. She was looking for a dissertation topic, and her father told a story that he fell while he was carrying her when she was a baby, and he went into a role that he learned from Taekwondo and got up like holding the baby with no issues. And that story was told through that family, and she remembered it. And we were doing some fall-related work, and she said, "Hey, can we do this?" And I said, "Sure, let's go for it." I was post-tenure, so I could take risks. I have a martial arts background. I taught people how to fall, way back when I was teaching martial arts. I knew it was possible, but when you look into the research, all the research really focuses on falls prevention, and that's incredibly important. My work, we're not trying to say don't do that, but we know no matter how good we are, people still fall, and they're still getting hurt. So, fall injury, fall death rate continues to go up. That's possibly because we're doing a really good job. Everyone's staying alive longer, and they're falling and getting a fracture. So that's sort of the impotence, is to understand that I had this great student who's willing to take a risk, and we just sort of had to come up. So, one of the things we had to figure out is, how do you measure falling, right? Because it's not like we can go to this, the store and buy a scale and measure it, right? There's no one. So we had to come up with that. That was interesting of itself. In a lot of martial arts, judo especially, they teach falling all the time, but they teach it from, a different approach versus research. So we came up with this method, and, we were measuring the impact forces. We use motion capture data, so those little reflective markers all over, so we can look at the configuration of the body as people are going. And, there's some other great groups that have done similar stuff, slightly different. Another really big researcher in the area, Steve Rabinovich, he's in Canada from Simon Fraser, and he has this great data set of about 2,400 falls in long-term care that they videotape, and you can go and compare. So one of the big things for our setup was making sure that our falls were lifelike. They're lab-based, but we still want to make sure the amount of time people are falling and such. So we were able to compare it to those falls. So the falls that we do in lab take the same amount of time as a real-world fall. So that's one
awesome.
Of the questions we get.
Yeah.
We're close. Obviously it's not the same as a real world fall, but we're in there. Dustin, feel free to interrupt me, because I'm just going to keep talking about the work.
No, I like it. One thing that I want to point out, and just so listeners are aware, I've not read this study, right? I've just kind of glanced over it, saw the topic, and read the abstract, right, like everyone else.
About it.
So I'm coming into this with I haven't dug into the details, but one thing that did pop out to me was who was in the study, because we'll talk about this concept of falls landing and training people how to fall and hopefully reduce their risk of injury, but what commonly the conversation typically comes up of okay, I'm not going to be able to do that with my people, right? They're at a risk of falling. They've got all kinds of complex medical issues. It's just not worth the time and the risk, right? So could you kind of paint the picture of like who was in this study, of who was included in folks that you were training them how to fall?
Yeah, so this study, we really were looking at what we call at injury risk. So there's various criteria out there. There was this big study, the STRIDE trial. I don't want to go into that, but one of my collaborators, Neil Alexander from University of Michigan, was on that trial team. And there's essentially risk factors for injury. So they had to have a history of falling, a history of suffering a fracture, a fall-related fracture, and or having balance impairment. And then the last one is if they're concerned about falling. So if you have one of those criteria, you're considered, and you're over 65. Sorry, everyone's over 65. You have one of those 4 criteria, you're considered at risk based on the literature, at risk for falls. So the other thing for this study that we had to do, because again, it was a research study, everyone got a bone scan. So everyone had thick bones. No one had osteoporosis. So one caveat to this work that we're going to talk about is because we're doing it in a research study, we screened out for osteoporosis. So we didn't, God forbid, we didn't want anyone to suffer a fracture during the study while we were training them. So we screened out those people. So there are people that are that I would be very cautious with doing the full standing height falls. So, one other thing that we haven't really gone into, Dustin, is that our paradigm, our experimental method, we do standing height falls. So we bring people in, they put on protective equipment, and they land on a crash pad. So it's a thick, I think it's about 16 inches crash pad that they land on. They're wearing these really wonderful hip protectors. We have them on with a helmet. They have wrist guards, knee guards. So we add them up with everything. And they lean into a tether. We release the tether and they fall to the ground.
Terrifying.
But we get people that are willing to do it. So they're excited to do it. And, before we train them, we watch to see how they fall. We measure how fast they're falling, what they're hitting. Fall-related injuries, and this sometimes gets lost in there, but I think it's important to point out. Fall-related injuries happen because the impact forces are greater than tissue strength, right, which is logical. Mm-hmm. So that's really when an injury happens. So you hit your hip, and with enough force, it's going to fracture. You hit your head with enough force, you get a TBI, right? Fall-related TBI. So one of the things we're trying to do when we teach people is we're trying to reduce the forces just with biomechanics and physics, and then we're also trying to have them land in places they won't get hurt. And there's another body of research that I don't really want to go into today, but I just want to mention. Kids, as they're learning to walk, they fall all the time, right? We're not taking our toddlers in for broken bones, right? And there's various reasons for that. One is that, they're 2 feet off the ground versus 5-6 feet off the ground, right? There's a difference there. But we all, so I think there's just a lot of differences that we can talk about. But let's get back to the study. Sorry, I'm going off in tangents already.
No, I love it. So I think for like when I came across this and saw like who was in the study, like it makes it more, I think, approachable for a lot of folks working with individuals that are at a risk of falling, that have had an injury before. And from what I gather, that seems to be, I would say, relatively new to the literature. Is that true?
Yeah, it's definitely true. Most of all the studies that have come before this study has focused on college students because they're young and healthy, and we can teach college students how to fall. That's probably not that impressive, but they can do it. Or they'll do things like falls from a standing height, which again is important, but most of the falls that we care about are not people falling over while kneeling, right? So, we're taking those people that are at much higher risk for falls or fall-related injury and then seeing if this technique works.
Awesome. So let's get into kind of the progressions and the technique that you all taught. And so just, with folks listening, right, which there's only so much that we can do. I did see with the article that there was some supplemental videos if folks have access to that. I haven't got to see them yet, but so y'all just know that they're out there on the internet, and we'll provide some links to that. But what does that progression look like with these folks that that came to you day one? What are you working on? How does that progress?
So the training is progressive, and like everything, we start off very simple. We start off with people seated on the ground, and actually we start off with them laying on the ground, and we'll just have them roll back and forth. So think bed mobility type stuff. They roll left and right. Once they can do that, they're comfortable with it, we'll have them sit up, and then we'll just have them start to slowly roll back onto their back and getting them used to this. And then from there, we'll have them crouch or do some variation of the crouch and go from a crouch or a kneel into a back fall. and we just make sure that they're comfortable and they're doing it correctly before we go. And then the last, we ultimately work up to them doing a standing height fall even from practice. And again, it's important that they're wearing the hip protectors, they're wearing the helmet, and they're landing on a crash pad, right? So we had access to a crash pad, but you can take a couple different mats and just make it a soft, compliant flooring.
Yeah. And when you're saying crash pad, like I'm thinking like folks that go bouldering with the throat underneath.
That's exactly what it is, right? It's it's a design to take the energy out when you fall because we're trying to reduce that force. So we're not dropping people on cement. We're not having them fall on cement. There's a whole other body of literature looking at compliant flooring and the floor, think of gym mats and things like that. Mm-hmm. That's obviously better to fall on than cement, but we often don't have control over the surfaces we're falling on.
Right. That'd be nice.
So it would be nice. Best thing would just be to, wrap us in bubble wrap and we'll be fine, but that's not the approach we can take.
What were, if you kind of go outside of the constraints of researching this, right? If you think like if you were implementing this in a clinic, working with someone, what were some of the like triggers for progression, or like what would you kind of be looking at of like, okay, let's try the next one?
Yeah.
Was it mainly like subjective report, or was it something that you were observing more objectively of like, okay, they're able to do this, then we're going to go to that? Like how'd you work through that progression?
It was a combination. So we always take the participants' feedback. So are they comfortable to go on the next step? We never forced anybody with it, so it was always that subjective report. How did that feel? And they would give us reports. And as long as it was good, we would go on. Mm-hmm. And then we were looking for specific, I'll say, tells or markers. So, we want to make sure one of the things that we taught people and focused on is that chin tuck. Fall-related head injury is horrific. It's very bad. We really think that tucking that chin really helps out. It also helps with the roll. So we teach the technique we end up teaching is really a tuck and roll type approach.
Okay.
So you're tucking your chin in, and when you're actually tucking your chin in, it causes that curvature in the back, which actually helps you go into a roll. So it's one of those mechanics that works. We're looking for them rounding the back. The other thing we're looking for is making sure when they're doing those landings that they're not landing on their arms, right? So we can think of falling on an outstretched hand. We want to give them expose them to falling without putting their hands out, which is a slightly odd technique to do, but we're trying to minimize those wrist fractures, those upper limb injuries.
Yeah. So were you all training specific, like different directions? Like, did you go backward, forward, to the side, or did you have one?
This study and the studies we've done in the past. So we started with falls to the side, and then this study we ended up doing falls to side and back. We don't have any published results on forward falls, although we're working on that right now.
Okay.
But there are definitely techniques if you look out, martial arts or combat sports and how to fall forward without planting, but it's a little bit more technical.
Yeah. Based on some of the data that you're familiar with, what is there a big discrepancy in terms of direction that most folks are falling?
So I would say, people, I think one thing we have to make sure it's clear to everybody, falls can happen in any different direction. There's different directions that tend to be more risky for injury, right? So when you're falling to your side or landing on your side, which might be more important, that you're much greater risk for a hip fracture. Falling backwards, again, depending on if you're not holding your head, you're going to hit the back of the head, so there's a high injury there, or high risk of head injury there. And forward falls also have a high injury of facial injuries, right? So the techniques that you're going to go into, really what we teach, and I haven't really gone into this yet, really one of the biggest techniques that we teach and focus on is lowering the center of the mass as they're starting to fall. So again, this sort of goes back to the paradigm we use, not to get into the nitty-gritty of the experiment, but we had people lean. So I don't know if you're old enough for the old V8 commercials, but the people would lean about 10, 15 degrees. What we were doing with that was taking away that recovery step. So there's a bunch of studies on perturbations and doing step training and things like that, and that's great, but we really wanted to look at the descent and the impact. So we lean people, we release the support, the tether, they fall to the ground. And really what we were looking at is as they're going down, they're going to bend, they're going to release, or they're going to go into a squat motion, which lowers their center of mass, which reduces the forces acting because it's a smaller fall, that they go into a roll, and then really that they tuck their chin. And then we also wanted to make sure that they're protecting their arms. So there were the four components.
Okay. So what consistent verbal cues have you found to be helpful and allowing these people to execute these movements. Because I'll just give you an example, just from my experience. I've done a lot of falls landing training in the context of a group. So in a group fitness environment, and which has been really interesting because I have to be very whatever kind of the biggest lever I can pull is, right? Because I'm not going to be able to get necessarily into the weeds. It's not going to be very I would say detail oriented, but it's like, what cue can I give someone to really set them up for success? It's going to be easy to execute because we can really get into the weeds of, all the different things that you need to be thinking about as you're doing this traumatic or during this traumatic event, right? So like, was there consistent verbal cues like that would consistently work well that people could execute?
Yeah, so during training, we really focused on that squat movement. So again, the experiment, when we were doing the standing high falls, we weren't giving cues because we wanted to see if people could learn it, right? So we had the experiment to see if they could learn it. During the training, we were really focusing on those 4 principles. So the squatting, the rolling, the arm, we call it the appropriate arm use, but not landing on an outstretched hand, and then the chin tuck. So we were just using those basic components that fit in. So like, the tuck, we tell people to scrunch up as they go down, roll their back. So, it's those basic components of it, but it's really weird to have people fall, right? Again, from a clinical standpoint, we spend the majority of our time doing everything we can to not have them fall. So it's good for you to try to do this in a group setting. And then I think too, I would, depending on the functional level of the group you're working with, probably not start with standing height. So maybe it's just having them sit on their butt and roll back. And it might just be something as simple as that. And that in itself is getting it to it. Because again, it's a frightening thing to go backwards or sideways. We're not, unless you're used to it, it's really odd. And I think more often than not, what we're doing is just giving people the chance to practice natural responses. It's not, anything we're teaching is not, it's not, we're not teaching them how to do flips in the air. It's just simple, basic movements.
Yes. And one thing that I'm curious how much it translates anecdotally. I've had folks report this, but most of the folks that I'll execute some of these movements on, which it's usually a backwards and a forwards fall, and it's usually a reduced range of motion. So they're going to an elevated surface or they are lower, like they're in a kneeling position, right? And so a lot of folks will kind of self-select out of a full range of motion, full standing fall. And I haven't seen any research on this, but anecdotally, a handful, right, which I'm not going to put a lot of weight on this, but a handful of folks said, man, this actually translated when I had a fall, when they performed it in kind of part practice or in a reduced range of motion.
Yeah.
Have you seen that? Has that been studied? What's your take on that? Because I think about like a lot of the folks that will watch or listen to this, they may be working with individuals that, let's say, may be using an assistive device or may spend a lot of time in a wheelchair, for example, like where they may be spending most of their time with kind of reduced range of motion, fall training in different directions. Like, will that translate, out in the real world? I think is the question.
So there's no published data that training like these fall techniques in the lab is going to translate to the real world. But just like you, when we ask people that have gone through our training, so we did the study and then we had a handful of people that we invited back and just to talk about it. We had 8 people do the interviews. 2 of them suffered a fall afterwards, and they both reported using the techniques that we taught them to avoid injury. So that is pretty strong. We're in the midst right now of trying to do a larger study to answer that exact question. So you're right on. That's what we want to understand. A lot of, I'll say like the perturbation training where they have these really fancy treadmills that they trip you and you have to take the recovery step. A lot of that work, like if in addition to the fact you might need $100,000 to get that treadmill, but that's a whole other issue. A lot of that work shows that if you get people better at taking that recovery step, their chances of falling goes down. So, and that's a very big, like stepping is a natural movement. And I believe what we're teaching is these natural movements. So I think we're going to see that extension to the real world. And again, there's a lot of these stories, like I told you, my graduate student's father who tells a story. I would give fall talks. I had a gentleman who served was a paratrooper in the Korean War, and he was convinced that he still knew how to fall 70 years later.
Man.
Or 60 years later. We don't have any data on that. But again, if you these people that learned how to fall, they still think they know how to do it. And it's a simple movement, and those are the ones that we retain for a long time.
Yeah, and what I love about exposing people to this is a lot of the folks that I've worked with, just their perception of the ground, right, is just very different than folks that do not regularly practice that skill or get to and from the ground. So when we start to talk about fear of falling and what that can do to balance and perceptions and
Yep.
choices they make in terms of what they may do or not do related to like physical activity, man, just like a lot of these people's perspective of a fall changes to where, the floor is not lava. It's like, all right, I'll be able to get to the ground and probably not get terribly hurt. And I probably have a strategy to get up as well. And just the fear seems to be relatively lower for folks afterwards.
Yeah, and again, we did a good job quantifying that, but I do believe people are less afraid of falling once they go through this because they've experienced, right? It's experience exposure. It's exposure therapy. And again, my research, in addition to working with older adults, I also do a lot of work with individuals with multiple sclerosis. So again, mobility impairment, heightened fall risk. And if you go talk to groups, people with MS, they'll tell you they learn how to fall because of numerous experiences. They'll have injuries and say, okay, I can't do that way. Let's try this way, right? So they're trying to avoid, if anything, trying to tone down that startle response, go stiff, which is, it's the horrible way to fall is a stiff. You want to be relaxed and lower. So I think it all plays in there. I think there is definitely a psychological component. I don't think I've done a good job or the team has done a good job recording it, but I think we can definitely see it.
Yeah. Yeah, I think, did you have an ABC in there?
Yeah, we did, but we ended up with this really unique group of people. They all had heightened fall risk, but their ABCs were really high, even at the beginning.
Okay.
And I think it goes to that bone density screen. Since everyone had, I'll say thick bones, had dense bones, we weren't getting people that were unconfident.
Got it.
And again, we had a selection bias. People aren't going to volunteer to do this fall if they're scared of falling.
Yep.
Right.
Fair enough. And for those that are familiar, ABC, the Activities Balance Specific Confidence Scale. And I'll put a link in there for that. We can get a good gauge of people's confidence with different activities. So, man, that's awesome. It's a fascinating study, and it's just really cool to see these types of interventions, making it in there and to be able to quantify just some of the changes. So, what for you, like, was there anything from this that was like really surprising? Like anything that really took you back that you were not expecting after running folks through this program?
So again, Dustin, you alluded to this, but this has been like a 10-year hiatus or 10-year journey to get here. Mm-hmm. The first study I did, we were really interested in hip fracture, so really focusing on hip, people falling and measuring forces of the hip. And I love to bring this up because this is how science should be done. I stumbled upon it, no pun intended. We had enough sensors, so we had everything censored up in the lower body. We had one sensor left, and we stuck it on the helmet just out of we needed to put somewhere. And you asked me how I got this approved. So I had to test a bunch of young adults to show that it was safe before the university would let me do this, right? So I bring all these people in and do it, no injuries, no issues. We bring in the first older adult to do the study, and he falls, and he has noticeable head impact, and we never saw that in the young adult. Same fall, same, he was normal height, we had a post-mortem afterwards. He didn't get hurt, but you could see his head, and we came up with this theory that this guy just had a big head, right? Because there's diversity in head sizes, and we were convinced this guy was a pumpkin head. I hope he's not listening. So, right, he was just one, and so we bring in our next older adult to do the study. Same thing happens. He hits his head. The guy doesn't have a big head. And then we realized that older adults have trouble controlling their head during the fall. So we found, and we were one of the first to show this, I think maybe the first to do it, we found that older adults were 3 times more likely to hit their head on the ground than young adults.
Wow.
Same mechanics, right? The height's more or less the same. Everything's the same. So there's some age-related differences, and, we can go on trying to figure that out. And so now we focus much more on head impact because we know 80% of geriatric TBIs are due to falls, the horrific outcomes post-TBI in older adults. But you look at the literature and how do you prevent a geriatric TBI, there is no data. They tell you to do fall prevention, but then they'll also, sentence below it, say there's no evidence that fall prevention actually reduces fall-related TBI. So one of the things I'm most excited about for the study that we just did is we saw a decrease in head impact. So does the head hit the ground or not? after the training, we saw a significant, really strong reduction in head impact in the folks that we trained to fall versus the control group. So that's one thing I don't think I mentioned. We had two groups. We had the group that we trained for the fall injury or how to fall. And then we gave another group balance exercises so that everybody was getting treatment. Everyone were controlling for that, and everybody went through the falls. Not surprisingly, only the group that we showed how to fall correctly, that we trained how to fall, had all these beneficial outcomes. Just doing the falls is what we want to say. But really, I think reduction in head impact as our proxy to head injury was really what we're really excited about, because there's nothing out there right now. If you have a patient come in and say, I want to reduce my risk for fall-related head injury, there's nothing you can do evidence-based.
Right. That's interesting. I've always assumed that, just from the other studies that I've looked at related to fall landing, in terms of like the technique of protecting your noggin, was more due to the risk or the impact of having an issue up there, right? Like the implications of you hitting your head are greater for older adults in the sense of their independence and quality of life. But I never thought that they were more at risk of hitting their head, that they're more susceptible to it. I didn't realize that. And up to 3 times then.
3 times is,
again, like a college kid, is that what we're comparing to?
Yeah.
That's really interesting.
Yeah, it's really, in some ways scary. So again, back to that Rabinovich data set with the videotaped falls in long-term care, they found that the head was actually the most likely to be injured per impact. So you don't hit your head as much as hip, because every fall I shouldn't say every, a lot of falls you hit your hip because that's your center of mass. Not all the falls you hit your head, but if you hit your head, you're much more likely to have a head injury than every fall that hits your hip doesn't have a hip injury.
Yep. Got it.
So head and the outcomes for head injury are actually worse than hip, but we hear a lot about hip injury. Not saying it's bad, but we haven't done a good job of trying to figure out how to prevent head injury, in my opinion.
Yeah. No, this is fascinating stuff. I love it. All right. Anything else you want to leave for the clinicians? Like, because I imagine a lot of folks that have probably maybe heard of teaching people how to fall, but maybe not have like executed this clinically, and probably some excitement around this, but also a lot of hesitation. What would you say to those folks that want to try to implement this in a safe manner, right, to protect their people, but also help them?
Yeah, I think, starting off simple, getting as much protective equipment, right? There's no reason they can't fall on pads. You use the wedges to reduce the height that they're falling. And just, it's really body awareness and teaching them slow techniques and progressing. I would not start with a standing height fall with no training. Start off on the ground, slowly work up as you get it. And I think the other thing, and again, this is outside the study, but I think the other thing that's incredibly important that we don't necessarily do is teaching people how to get up. One of the lines I tell all the time, and I think it's worthwhile, as long as we have gravity, we're going to have falls. So we have to figure out how not to get hurt, and then part of that is how to get up. And as we age, muscle loss and such, we have to potentially use different techniques and do it. So I think just starting off slow, using a lot of protective equipment, and going into it and making it, my other adage is we always try to make it fun. So, and I can tell from you that's what you do too. So
I try. Effort. I can only promise effort.
Yep. I hear you.
But I love it. I appreciate that. Dr. Jake Sosnoff, everyone that's watching or listening, check the show notes. I'm gonna link to your faculty profile. I'll link to the study, the FAST study, is titled Strategies to Minimize Fall-Related Injuries in Older Adults at Risk of Falls, the Falling Safely Training Study, the FAST study. So I'll have a link to that. And I'll probably also go ahead and throw some links maybe on Amazon, from Amazon, in terms of like a crash pad, and maybe some ideas for maybe some of the protective equipment as well, just so you all have resources to get this thing going and try it out on yourself first, and then
always on yourself first.
I love it.
And,
all right,
throw my email in there too. They're happy to take answer questions and such. I'm happy to help out.
Awesome. I appreciate your time.
All right, thank you for having me on.
Awesome.
All right.